This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from Child's Nervous System, published in 2026, titled, "What is the Best Surgical Approach for Pineal Region Tumors? A Systematic Literature Review and Anatomical Comparative Study" by Palombi and colleagues.
This is a topic that hits home for anyone who has spent time in the suboccipital or occipital corridors. Pineal region tumors are notoriously difficult. You're dealing with the anatomical no man's land at the junction of the midbrain and thalamus, surrounded by the most unforgiving neurovascular structures in the brain.
Exactly. The authors point out that despite decades of refinement, we still don't have a consensus on the gold standard. This paper tries to answer that by combining a systematic review of nearly 1,800 patients with a hands-on anatomical study using tumor simulations.
It's the robust design. Let's start with the systematic review. What did the data tell us about what surgeons are actually doing in the OR?
They reviewed 27 studies covering 1,774 patients. It turns out the community is split almost down the middle, though the occipital interhemispheric transtentorial approach, the OITA, takes a slight lead at 42.21%. The supracerebellar infratentorial approach, or SCIT, follows closely at 38.27%.
Those are the big two. Poppin and Jameson would be proud to see their legacies still dominating the field. But the real meat of the review is the complication profile. If the outcomes are similar, we choose our approach based on what we want to avoid. What were the specific risks for each?
This was quite striking. The SCIT approach was significantly more associated with cerebellar complications, which makes sense given the retraction, as well as CSF reeks and meningitis. Interestingly, Perinaus syndrome was also more frequent in the SCIT group, with a p-value of less than 0.005.
That's an important clinical pearl for the residents listening. Perinaus is often thought of as a presenting symptom of the tumor itself due to pressure on the tectal plate, but the SCIT approach, perhaps due to the upward trajectory or manipulation near the colliculi, carries that higher post-op risk. Now, what about the OITA?
The OITA's Achilles heel remains the visual system. It had a significantly higher incidence of homonymous hemianopia, p equals 0.0011. This is the classic trade-off. You avoid the cerebellum, but you risk the occipital lobe and the visual cortex during retraction.
That's the perpetual dilemma. But the paper doesn't just stop at the literature. They performed an anatomical comparative study. I found their quadrant system for visualization very practical. Can you walk us through how they divided the pineal region?
They divided the surgical field into 4 quadrants to measure exposure. Q1 and Q2 are the inferior quadrants, essentially the lower half of the tumor and the tectal region. Q3 and Q4 are the superior quadrants, moving up towards the splenium and the internal cerebral veins.
And I assume the infratentorial approach, the SCIT, owned the lower half.
Precisely. The SCIT provided the broadest exposure of the inferior quadrants, Q1 and Q2. However, it struggled with the superior quadrants. Q3 and Q4 are notoriously difficult to see from below because the tentorium and the deep veins act as a ceiling.
But they looked at a modification to the SCIT, didn't they? The SCIT plus a tentorial incision.
Yes, the SCIT plus. This was one of the key findings. By adding a tentorial incision to the standard supracerebellar route, they were able to significantly expand the versatility of the approach. It facilitated visualization of those supratentorial quadrants, Q3 and Q4, which are otherwise blind spots in the standard infratentorial corridor.
That's a game changer for bulky tumors that extend superiorly. If you can stay infratentorial but still reach the top of the tumor by cutting the tentorium, you might avoid the occipital retraction of an OITA. But what about the OITA itself? How did it perform in the quadrants?
The OITA offered the best visualization of the superior ipsilateral quadrant, Q3. Because you're coming from an interhemispheric route, you have a more direct line of sight to the top of the lesion.
It sounds like the best approach is entirely dependent on where the bulk of the tumor sits relative to the tentorial apex. But we can't talk about the pineal region without talking about the venous complex. The vein of Galen, the internal cerebral veins, that's usually what keeps us up at night. How did the authors use the venous anatomy to guide approach selection?
This was a major focus of their tumor simulations. They found that the relationship between the tumor and the deep venous system is perhaps the most critical factor. They suggested that supratentorial routes, like the OITA, are better for lesions that are primarily anterior to the veins. Conversely, the infratentorial corridors, like the SCIT, are better for tumors with posterior extension.
That makes perfect sense. You never want to be working through or around the vein of Galen if you can help it. You want the veins to be displaced away from your working window, not sitting right in the middle of it. If the tumor is pushing the veins upward and forward, you go in from below, SCIT. If the tumor is superior and the veins are pushed down, you come from above, OITA.
Exactly. And the study also mentions that tentorial anatomy itself should dictate the choice. If a patient has a very steep tentorial angle, the SCIT becomes much more difficult because your working window is narrowed. In those cases, the OITA might be safer regardless of the tumor quadrant.
Let's recap for the residents. If you're looking at a pineal mass on MRI, what are the 3 must-check items Palombi and his team suggest for approach selection?
First, the tumor's relationship to the deep venous system. Is it anterior or posterior? Second, the extension within the quadrants. Specifically, is it inferior, Q1, Q2, or superior, Q3, Q4? And third, the patient's specific tentorial anatomy and the angle of the slope.
And don't forget the complication trade-offs. If the patient is a professional driver or artist, maybe you're more hesitant about the OITA because of that risk of homonymous hemianopia. If they have underlying cerebellar issues, maybe the SCIT is the higher risk.
It really highlights that there is no one-size-fits-all. The authors conclude that selection between SCIT and OITA must be individualized. And I think the mention of the tentorial incision expanding SCIT versatility is a great middle ground for those challenging cases that bridge both territories.
It's a reminder that neurosurgery is as much about geometry and trajectory as it is about technique. This study gives us a more objective framework for those 3 a.m. surgical planning sessions.
Definitely. It's about choosing the corridor that provides the most visualization with the least amount of critical structure manipulation.
Well, that's our time for today. A big thank you to Palombi and the team for this comprehensive work in child's nervous system.
Thanks for listening to the Neurosurgery Hub podcast. We'll link the full study in the show notes.
Until next time, keep looking at those scans and refining your corridors. I'm Dr. Aris.
And I'm Dr. Alara. See you in the next episode.